CMEs. I have no financial relationship related to anything I'm going to talk about today, so nothing to disclose. I'm going to talk about trauma disorders and treatment approaches from just for an informational standpoint in working with this population. So hopefully today you'll be able to identify and describe what are some of the characteristics that differentiate stressful events from traumatic events, because we tend to use those terms interchangeably, be able to talk about the key characteristics related to trauma reactions, what's common and expected, and then what are the pieces that are related to a disorder or a disorder of non-recovery. And then talk about the different components that are recommended or considered best practice standards for treating trauma conditions, and how you may be able to utilize some of those practices in your clinical work with this patient population. So I think it's important to, before we talk about disorders related to trauma, to be able to differentiate what is the difference, because these exist on a continuum. So the first place to start is by understanding what are reactions to stress, acute and chronic, and then that will allow us to sort of delineate what is the difference between a stressful event and a traumatic event. Now, what I like to first introduce people to is the idea that not all stress is bad, that just like not all trauma is necessarily bad, that as humans, we have a natural capacity to learn from, to accommodate, and to actually strengthen both psychologically, physiologically in response to some of these events. And so there is an optimal level of stress that helps us to be activated, engaged, maintain our performance, and so we want to kind of stay in that yellow zone. Now, it does have a tipping point, and the same thing with traumatic exposure, that once we hit that tipping point, that's when we start to see things that sort of break down our resources. And this is why chronic stress can be so devastating, and why we have discussions about a burnout, and other things that really start to break down the system and start to look very similar to mental health conditions, anxiety disorders, depressive disorders. So just recognizing that stress exists on this curve or on this continuum, and so does traumatic symptoms. So I'll talk about that in a minute. So just specific to stress, and we know that this applies to the patients that we treat because they have typically chronic stress or ongoing psychosocial stressors that are going to impact their ability to engage and be retained in whatever treatment it is that we're providing. But recognizing that that stress isn't in and of itself a bad thing, that it actually helps people to build resiliency and improve their functionality. But we need to recognize that we want to keep them in that yellow zone and not flip into where they're overwhelmed and all of those resources are overextended, so that they're starting to exhibit symptoms of chronic stress. So just like with trauma, everyone's response to stress is going to be different. It's going to vary by the intensity of the stressor, how much resiliency they've developed over the course of their life, their ability to cope or the coping style, and then what kind of supports they have, both internally and externally. But at the end of the day, I think it's important to convey to our patients and also for ourselves that we as humans have an innate ability to adapt and move through, so cope effectively with stressors, even chronic stress. We just have to think about that balance scale and make sure that we're accommodating or encouraging people to accommodate. If the stress is going to continue, what can they do to balance that? How can they keep that the reservoir that helps them to sustain filled? So what kind of resources do they have to maintain? Now, this is what's called an adaptation model. It looks very similar to that stress curve, but it's one way of thinking about whether we're talking about a serious stressful event or a traumatic event, that all people have a baseline, whatever that baseline may be. And that can fluctuate depending on how much resiliency they have, but it's sort of where their system stays in a balanced state, regardless of what's going on. Now, a stressor or a trauma can occur. It may be threatening, or it may actually be exhilarating, like the birth of a child, or starting a going back to school, starting a new job. Any of those things could be positive, but they could be significant stressors. So what's going to happen within this model is we see an initial dip in how that person functions. So it may be within the first couple of hours to first couple of days after the event has occurred, that we'll see maybe a shift in their functioning, a decrease in how they're functioning, and then that's followed by what's called an alarm response, which actually helps them to function at a higher level than they normally would. So it's sort of a rallying of resources. And anybody that's dealt with a significant stressor in their life may have had this experience where all of a sudden they may be able to get by on less sleep. They may have a little more energy. They may just be functioning kind of in overdrive to be able to compensate. Now that only lasts so long, but this process is what builds that resiliency. So that resistance is what's sort of flexing that muscle. If those resources are not replenished, and if the stressor continues without additional resources, then what's going to happen is exhaustion is going to set in, and we're going to see a significant drop in their functionality. And this is why typically we see these types of shifts happen about a month to 2 months after the event has occurred. Now, people can return to that baseline if they have enough supports or coping, or the stressor remits, or it will instead turn into a pathological response. And that's where we start to see illness and things that are associated with premature death. So with stress intervention, if it's an acute event, typically nothing is needed to happen because the event will end within a short period of time and people can return to baseline. It's this chronic stress a piece that really requires some form of intervention. And that could look like traditional psychotherapy or pharmacotherapy, lifestyle changes, but something usually needs to happen to prevent that precipitous dip from happening with the stressor continuing, right? So that chronic stress piece is something that it very much affects our patients because of all of the psychosocial issues that are going on in their life related to marginalization or ongoing issues within society, resource attainment, poverty, chronic homelessness. All of these things present a chronic stressed state that is going to look very similar to trauma symptoms. So, what makes trauma different from stress? So, trauma actually has an objective definition, which means actual or threatened death, serious injury, or sexual violation. If it's not falling into that category, then it doesn't qualify at the level of trauma. There are multiple ways that people can have trauma exposure. They can either directly experience it, so that would be physical, sexual assault, domestic violence, severe car accident, natural disaster, or they could witness it. And this needs to be something that happened within their physical vicinity. This category has to requires two variables. So learning of a violent, actual, or threatened death of a close family member, but with the vivid details. So it needs to be someone that is very close in this person's life, child, parent, or that type of a relationship. And they need to actually get the vivid details to be able to reconstruct what happened in that traumatic event as if they were witnessing it. So this is an example would be, a mother getting the copy of the crime scene report related to a violent car accident that where her child died, right? So something like that would qualify because the mind has actually restructured the event as if they have witnessed it, but without the vivid details or without that close connection, this wouldn't qualify. So a natural death of a loved one, although that could be very stressful, wouldn't necessarily rise to the level of a trauma. And then the last category is typically affects people that do some sort of work associated with trauma, trauma content. So they're repeatedly experiencing sort of the aversive details of a traumatic event. So first responders, police, EMT, even funeral workers, mortuary workers, police detectives, people that have to see the aftermath of this traumatic event or video footage on a repeated basis may qualify for this category. So this is the only definition of what would rise to the level of trauma. So we can think about traumas as a specific extreme type of stressful event. So if you think about it on a continuum, traumatic events are stressful events, but stressful events are not necessarily traumatic, right? So it's kind of one directional. And that's important to be able to differentiate, even though chronic stress symptomatology can mirror or look very similar to trauma symptoms, and they can have similar outcomes in terms of disorder. But recognizing that traumatic events include some unique presentation that have to do with re-experiencing of the trauma, have to do with sort of a perseveration or rumination of a particular event or type of event, where stressful or stress-related presentations tend to be a little more profuse. So that's important because that helps us to think about how we treat these conditions. Now, talking specifically about trauma, that we can break traumatic events into different categories as well. So one level is strain versus shock. So similar to acute and chronic stress, shock trauma is a acute event, so a single event, short in duration, high in intensity. And strain traumas are multiple events that tend to be longer in duration and less intensity. So more in that chronic category. Now within strain, we can break that into chronic strain traumas. So like domestic violence might fall into this category, where it was a shock trauma the first time the physical assault happened or the sexual assault happened, but the 200th time it happened, it's now become a strain trauma. So the intensity has dropped because it's predictable, because there's been some level of habituation to it. Complex strain traumas are specific to events that occurred in childhood at the hands of a caretaker. So, complex strain trauma tends to result in poor outcomes because it happens during important points of development where children don't necessarily have a lot of other means to coping or adjusting to what's going on. And when it's happening at the hands of someone who's responsible for taking care of them, that can have some really long lasting effects in terms of how that person functions and how their psychology is wired. So in general, childhood traumas tend to be more impactful than adult traumas. That's not a hard rule, but that just tends to be, in general, that adult events seem to have less detrimental impact, that people tend to be able to recover quicker or without intervention when it's an adult event versus a childhood event. One study that really highlighted that was a longitudinal study called the ACEs study, and the ongoing ACEs work that has really shown that the things that happen in childhood, or what falls into these category labeled adverse childhood experiences, really has sort of a domino effect to the development of that individual. And so if something happens in childhood that's significant, it can disrupt how that person's brain develops, how they are able to interact with others socially, how they think, how they're able to regulate emotions. It places them at much higher risk to adopt risky behaviors of all kinds, which then increases their risk of all sorts of mental, physical conditions and social problems. It can unhook certain genetic vulnerabilities, which has that epigenetic piece, and it can also cross generations. So that's how we see sort of that intergenerational transmission of the impact of trauma, both within communities or within entire groups. So that's just one note on the impact of childhood trauma. Now, similarly to how we respond to stress, how people respond to trauma also varies by the type of trauma it is, how close they were. Did they experience it? Did they witness it? Were they just exposed to it as part of their work? How much resiliency they've developed, or sort of that resource reservoir. So sometimes having had experienced previous traumas is protective because they've sort of built that muscle. They have means that they can accommodate it. That's how we'll see people that have multiple traumatic histories they're doing just fine, versus someone who maybe this is the very first time anything like this has happened to them. They have very little resiliency. It can be more detrimental. But previous traumas can also overwhelm the system. So it could deplete that reservoir. So when that next trauma comes along, they will have a poor outcome. And this is where the stress piece can cross. So people that have current difficult stressors going on in their life, it makes them more vulnerable to the impact of that traumatic event. The relationship to the abuser, is it someone that's known? This is particularly true if it's a complex traumatic experience, how many coping skills they have, the response of the support system, and then I talked about the levels of stress at the time, and then how they perceive the event. So what is the meaning that they make about that event, which is one of the reasons why, sorry, somebody not on mute. I don't know if folks could just check that they're on mute, that would be great. This is why it can be why we believe that there are higher rates of disorder related to sexual traumas because of some of the meaning that gets distorted around those types of events. So it's important to understand that when we think about disorders related to trauma exposure, that we consider these disorders of non-recovery. And that's because the vast majority of people will experience trauma in their life, and the vast majority, upwards of 70 to 80%, will recover without any intervention, which is another reason why we don't diagnose conditions like PTSD for a period of time after the event, because everyone will have symptoms of a trauma reaction after they've experienced a trauma. But by and large, the vast majority will get what's called natural recovery. They will return to baseline without any kind of intervention. And we've done a number of studies that have shown if we intervene too quickly, we can actually disrupt that system and cause people to have a poorer outcome than if we just let them recover on their own. So the vast majority are going to experience these symptoms right after, but that's an adaptive response. That's that alarm system kind of activating that I showed you in that adaptation model. It's not necessarily the sign of a disorder, that we're not going to look at that until we see that precipitous dip for a period of time after these events have happened. So that temporary drop in homeostasis with eventual restoration and adaptation is the normal response that we would expect after a traumatic event. And these people that are getting natural recovery, or those that go on to need intervention and actually get recovery through treatment, are going to get this thing called post-traumatic growth, which allows them to shift the meaning that gets made about that event, to rally their coping resources, and to be in a better position to adapt should another trauma occur in their life, or even more difficult stressors occur in their life. They're going to be better able to accommodate it, better able to move through it. So this is a really valuable thing that can occur after a traumatic event. So what are the common reactions that we would expect to see across anyone who experiences a trauma? So you can think about those common reactions as the short-term or acute response or alarm response, right? That activating of the system that's going to occur to 99.9% of people right after a trauma occurs. And it may include some functional impairment, but keeping in mind that that is typically temporary. So disruption in sleep, disruption in how they're interacting with others, maybe poor emotional regulation, or just increased negative emotionality, increased nightmares, increased vigilance. All of those things are very typical. But only about 3 to 10% are going to go on to maintain those short-term symptoms and have them transition into long-term symptoms, which is then where we would look to diagnose a condition. Now, I think it's important in categorizing any of the symptoms related to trauma as starting within the nervous system. That trauma directly impacts the limbic system and other structures of the brain called the HPA axis, and that shifts how the brain is producing certain hormones or other neurochemicals, which have very predictable psychological and physiological symptoms associated with them. And so that's why we always kind of start with helping people understand that alarm system is being activated in the short term, and then it gets stuck on, which then explains a lot of the symptoms of chronic trauma conditions. So what are the different disorders? Now we talk most of the time specifically about PTSD, which it falls under the category of trauma disorder. But I think it's also important to understand that that is not the most common outcome, that when people shift into a pathological response, so that sort of chronic traumatized state, that in fact mood disorders, anxiety and depressive disorders, and sleep disorders and substance use disorders are more frequently the outcome. And so recognizing that if a person has a trauma history, if you do a timeline and you can directly correlate the onset of whatever problematic symptoms they're experiencing to that traumatic event, then maybe you're actually looking at a trauma condition and not a standalone mood condition. There's another thing that's not in the DSM, but that often people will get labeled with something like borderline personality disorder, when in fact they may be experiencing complex trauma, or what's sometimes called in the literature complex PTSD. And so these are the symptoms of PTSD or subclinical PTSD with a number of interpersonal symptoms, disturbance in identity, mood dysregulation, adoption of risky behaviors, and attentional issues that kind of mirror ADHD. And this is directly related to the experience of complex trauma. So again, the trauma that occurs in childhood at the hands of a caretaker is going to have a more profound effect to the system, and it's going to impact how that person is organized psychologically. It's not necessarily a personality disorder, though. And so I believe that this will likely be included in the next iteration of the DSM. So I like this graph because it breaks down people who've experienced a trauma in their life, the prevalence rates of conditions. And so you can see that PTSD is in fact the lowest prevalence rate at 3.5%. And that does vary by gender, but the highest prevalence rate is an anxiety condition. So when we're working with people with substance use disorder, there's a high incidence of a comorbid anxiety condition. And that is oftentimes directly connected to their trauma exposure, not necessarily something that is just constitutional, right? So that's just important to kind of keep in mind. So I like to think about trauma conditions as operating within this Venn diagram, that people will sometimes experience one or more of these, or they may experience one or more of these at different points in their recovery timeline. And it's important to understand that conceptually, because this may inform how we actually go about treating these conditions. So shifting into treatment, there are numerous evidence-based treatments for all of the trauma-related conditions. They've been well studied. They fall into the category of evidence-based treatment because they've done random assignment, and we've been able to show valid and reliable outcomes for these specific interventions. All of these interventions fall under a CBT umbrella. So that means that we're using specific techniques that are housed under changing someone's behavior, their thinking, or both, in order to change sort of how they're functioning. At the first level, we can use things called anxiety management techniques, which is really helpful, particularly at the beginning of treatment. So these are things where we might apply a seeking safety protocol would fall into this category. PTSD 101 would fall into this category. Relaxation training, some of the social skills training or distraction techniques, thought stopping, grounding. All of these things can be very helpful at helping people regulate enough to be able to engage with the more intensive treatments and be able to show to those appointments and benefit from those appointments. Because if the nervous system is constantly in that hyper-aroused state, it's going to impact how they're thinking, how they're able to attend, what they can remember, regardless of what their diagnosis is, right? So this can be a great first step to getting people kind of grounded enough to be able to move into one of the EBPs to treat the majority of the symptoms. Now, within some of the treatment protocols, whether we're talking about an anxiety condition or we're talking about PTSD, there's one category that's heavily behavioral, and they fall under the umbrella of exposure therapy. So these are techniques that are really help to gear patients to start to approach instead of avoid the things that they have linked to that traumatic event that can look like a specific phobia, can look like generalized anxiety or OCD, can also look like PTSD. So we have a number of exposure-based treatments that we can use to really get at the behavior of avoidance and help them to start approaching and habituating to those things. The next category would fall under the umbrella of cognitive techniques or cognitive therapy. And that's where we're really going after all of the distorted thoughts or dysfunctional thinking that has developed as a result of their trauma exposure. And if we can teach them techniques to identify, change, and replace those distorted thoughts, then we're going to get a change in their behavior. So here's a list of all of the different techniques that are endorsed by the National Center around what we would recommend as EBPs for treating trauma-related conditions. And you can see there's a lot of similarity in terms of the categories. So cognitive processing therapy, prolonged exposure are gold standards for PTSD, interpersonal psychotherapy, cognitive behavioral therapy, and ACT for depression, and then the same thing for anxiety conditions. Now, some people have concern that people with substance use disorder, that we want to treat their substance use disorder before we may treat their trauma condition. And the National Center for PTSD actually says, no, we don't want to do that. And in fact, SAMHSA endorses both prolonged exposure and cognitive processing therapy as interventions that we want people to do at the same time. That if we try to treat one instead of the other, we're going to be less effective, and that there is almost no evidence that supports that people will use more or will relapse when starting one of these interventions. And so if we can treat the trauma symptoms at the same time as using evidence-based medications or other things to treat the trauma condition and get them engaged in one of these EBTs for their trauma condition, they're going to be more successful at decreasing their use. So that's all I have on this particular topic today. Are there any questions before we turn it over for the case?